Good afternoon, everyone. It's a pleasure to be here, and thanks, Dr. Kumarvel, for the kind invite. I think most of my material has been stolen by Soundaram, so there'll be a little bit of overlap, because both growth and puberty come from pituitary, so I think there is a bit of overlap, but it also gives a small introduction into my topic. I'll be using Tamil in between because I'm quite comfortable with Tamil. Some things cannot be said in English as nicely as in Tamil, so I will start going. So we look at avara potta avarada molekku, thavara potta thavarada molekku. So your genetics will determine your growth. So your mid-parental height will determine how tall you're going to be, at least most of the time. And when you deviate from the norms, it means you're actually affecting your growth, and you're going to look for reasons on why you deviated away from your parents. ஏன் பெற்றோரிடமிருந்து நான் விலகி சென்றேன் அப்படின்னு பார்க்க போகிறோம். So this is a normal growth. So there's a green point at the end of the slide, which is at 18 years, that's your absolute expected height at an adulthood. So that's mid-parental height centiles on either side. As Dr. Soundaram said, 2 standard deviations on either side will actually predict that you're within normal centiles for your parents. So this is a normal growth chart. So I will actually re-emphasize growth charts again and again. Any investigations or anything else, biochemistry will come after biology. So the child is of utmost importance compared to any investigation you would do. So anthropometry takes precedence over all investigations that you would do in any child. So the parents are worried about the height of their child. Their child is the shortest in the class. But you have to remember how tall the parents are for you to worry about whether the child is really short. So you have to look at physiological, either it could be familial or constitutional, as Dr. Soundaram had shown, constitutional delay in growth and puberty. You start slow, you're a late bloomer. மெதுவாக வளர்ந்து ultimate height you will reach what your parents have to be, that your constitutional delay in growth and puberty, or you have a pathological reason for why you are short. So as already mentioned, the definition of short stature would be less than -2 SDs for age and sex, a growth velocity of less than or equal to 25th centile. So remember, longitudinal growth is the most important predictor of how this child is going to be ultimately. A one-off height taken at one point in time does not throw much light on how this child to be. So earlier you start looking at the child, the better you watch, there'll be many more clues for whether you need to proceed or you don't have to. So growth velocity of less than or equal to 25th centile, crossing centiles substantially. You go across centiles, you cross 2 major centile lines on your growth chart, it is important. If you are less than minus 1.5 SDs from the mid-parental height centiles, again that is considered to be short stature. So you are looking at the history. How is the family? What happened at birth? What was the birth weight of the child? How was the antenatal period? Did the mother have any issues during pregnancy, including pregnancy-induced hypertension or gestational diabetes, which was not managed very well, or any other issues in the antenatal period? The mid-parental height, did the child have any chronic illness? So if a plant has to grow well, the environment has to be good for the plant to grow. The same way, all parts of the body has to grow well for the child to grow absolutely along the centiles it is supposed to grow in. So chronic illness is important. And also remember to always ask for psychosocial deprivation. If the child has lost a dear one, if the child has lost its parents, had a lot of anxiety, that can also be an important marker of delaying and reducing the growth potential of the child. So psychosocial deprivation is something you should definitely look for. And then you go along into physical examination, which I think everybody would do. Accurate height and weight, and if possible longitudinally, at least 2 readings, a minimum of 6 months apart, will throw a lot of light on where you're going. Bone age, chromosomal analysis for all girls. Soundaram showed a girl with Turner syndrome who has a short neck, cubitus valgus, has short 4th metacarpal. Please remember, the only important clinical finding in any child with Turner syndrome, absolute diagnosis is short stature. Any other clinical finding can be only found in a certain proportion of children with Turner syndrome, but 100% of specific Turner syndrome, unless they are a Turner syndrome variant, will be short. So that's one specific clinical finding. You don't have to have any external marker of Turner syndrome to ask for a karyotyping. If a girl is short, less than 2 SDs from the parents, or less than 2 SDs for the age, and less than minus 1.5 SDs from the parents, this child warrants a karyotyping. And at a dependable lab. I will show some pictures on why it has to be at a dependable lab. Then you do thyroid functions and all chronic diseases, including your liver functions, your renal, and all other and electrolytes or renal tubular acidosis and anything else. Growth hormone stimulation tests, you can do several agents. I'm not a big fan of insulin because I worry about it, but it's one of the best ones to do. I use sequential testing of use growth hormone stimulation by 2 agents is the best way. You're trying to prove you have enough growth hormone. You're not trying to prove you don't have. Even one single value which crosses a value of adequate growth hormone indicates this child has adequate growth hormone. You will still treat the child only based on anthropometry, but your dosage will be different. The amount of growth hormone you will choose will be different. The expectations you have for the child, the counseling you will give to the parents will be different. Your treatment will depend on the anthropometry. But you will still use growth hormone, but the expectations and the outcomes will be different on whether you are growth hormone deficient or sufficient. So this is a family, again, both the parents are short, the mid-parental height is short, and this child is growing along the familial centiles. So this familial short stature. So this is constitutional delay in growth and puberty, which was actually shown by Dr. Soundaram. This child was growing reasonably well up to 2 years of age, then drops off on the centiles, but does not touch absolutely very low values, and then will have a delay of bone age by about 1 or 2 years, and then will ultimately start creeping up on the height centiles a bit later than the others, follow one of the parental or a familial person, and then ultimately reach the height potential they have to be. So this is constitutional delay in growth and puberty. So this is a child who's very short, far below the mid-parental height centiles. So you draw a line to the 50th centile and drop it down, and that chronological age is 12 years, but the height age is about 7.5, and the weight age is also less, but the height age is affected more than the weight age. So that was a probable growth hormone or a hormonal issue which caused short stature. So these are 2 children. One is a girl who's 5 years of age, which is the girl wearing a white dress. She came with puberty, with bleeding per vaginum. She had breast, which was stage 3. She did not have pubic hair, but she was shorter than the girl who's standing of a similar age who had come for a respiratory illness. In puberty, as Soundaram mentioned, estrogen is the most, I think somebody else mentioned, estrogen is the most important hormone for progression of your bone development. So if you are short, in spite of precocious puberty, that is probably hypothyroidism. And this is a boy who has a poorly controlled type 1 diabetes and Mauriac syndrome. So these are chronic illnesses which has affected the growth and crossed centiles substantially downwards, crossed 2 major centiles. So this child has short stature due to chronic illness. So you have to correct the primary disease before you start treatment. So these are a set of twins. So this child has already gone through menarche. She is very short, and they came after a long time, but still her bone age was sufficient enough for us to intervene, and she achieved reasonable growth. The second one is also a growth hormone deficiency. The last one is a tragedy. That's an HESX2 mutation, which had been missed all through her age. She is 22 years of age. She came with hypoglycemic convulsions and multiple pituitary hormone deficiencies. She's fused all her bones. She's not grown tall. She's not had puberty. She is living with her mother and looking at the society going ahead around her, and a very, very sad scenario. If they had picked it up earlier, probably we could have helped this family. So growth hormone deficiency, we treat with recombinant human growth hormone. The daily growth hormone dose is 17 to 35 mics per kg per day. Or when you use body surface area, it's 0.7 to 1 milligram meter square body surface area per day. Particularly in obese children or Prader-Willi, this is the dose we use. Or 5 to 7 mg per kg per week. These are growth hormone deficiency doses. When you use an idiopathic short stature, when you use growth hormone in SGAs, or when you use in Turner syndrome, the doses are far ahead. And as I already mentioned, your expectations are lower. So dose in non-growth hormone deficiency states is higher. We use weekly human growth hormone somatrogon 0.66 mg per kg per week. If you look at their original study, the dose of 0.45 and 0.66 mg per kg per week did not have too much substantial difference. So I actually start in significant growth hormone deficient children at a lower dose, and if their growth velocity progresses very well, we stick to that. If their growth velocity does not progress very well, then we step up the dose to a max of 0.66 mg per kg per week. And this is available in the government setup also. So we have a significant number of patients in Coimbatore Medical College, Tirupur, Erode, Salem. And I would say our scenario in the western belt of Tamil Nadu is really good. Most of our children never go without help. So this is, of all the patients who have ever been referred by my husband in my entire life, this was the only child I think I saw. So he's a neurologist, and this child came with convulsions, recurrent convulsions, and not controlling with anything. They were worried with puberty and they sent it to me. This was multiple pituitary hormone deficiencies which had been missed. This child had hypoglycemia in the newborn period, prolonged physiological jaundice in the newborn period. All were clues which were lost all along by pediatricians, and ultimately came to me with multiple pituitary hormone deficiencies. So remember, you have to first replace cortisol. You start thyroid hormone, you might not crash, but I have seen children crash when you start high doses. But usually, always the dictum is to replace hydrocortisone first, then do a thyroxine replacement, achieve euthyroid status, then do a sex steroid priming growth hormone stimulation test, start growth hormone, then go on to establish puberty if they have not gone into it spontaneously. So she had all 5 hormones in the anterior pituitary which were lost. So this was the same girl ultimately after achieving a reasonable amount of height and going through puberty. So this is one of our boys, a friend of mine actually, because he's been with us for so many years. That was when we started growth hormone. And that is a mark which was done by my teacher, Professor Raghupati. So we started growth hormone there, and look at where he went. So once he reached into normal height centiles for his age, we thought of stopping growth hormone. This was in the pre-availability era in the government setup. So the father went into merchant navy to get growth hormone for him. After he achieved 170, he said, Appa, I beg you, can you give some more? He said, I've been already working for so many years, I'll give it for some more years. He reached ultimately 178 centimeters. Human growth hormone therapy in non-growth hormone deficient states. SGA with no catch-up growth by 2 years, Turner syndrome, Prader-Willi, idiopathic short stature, SHOX gene haploinsufficiency, Noonan syndrome, chronic kidney disease. I have used in all of these scenarios. Unless you are asking for growth hormone from the government setup, you don't have to do a growth hormone stimulation test in these children unless you have a specific reason. Otherwise, they qualify for growth hormone therapy only on basis of anthropometry and clinical features. So this is a slide from my team in New Zealand. So that's Wayne Cutfield, who's my supervisor. So they went home and collected the growth hormone in the fridge because it's supplied by the government free there. And they looked at the growth depending on how many doses had been missed. 66% of children who missed more than 1 dose of growth hormone per week had a significantly reduced height velocity SDS. So that was I would say a stimulus for the start of research into long-acting growth hormone. So daily versus weekly human growth hormone therapy, better compliance with once weekly doses, reduction in the number of missed doses. It is non-inferior to daily human growth hormone therapy, but the adversity on the other side, it's approved only for growth hormone deficiency states currently. The other studies will start soon. It's definitely more expensive. The patients who achieved similar change in height SDS, whether they used the long-acting or the daily growth hormone, the growth was almost similar in either group. The adverse effects, I think most of us would already know, are very, very rare. We don't know the long-term effects. The SARS data, which is being maintained in Europe over the last 40 years, did not show significant side effects except in rare occasions. But the only one which we can never predict is slipped capital femoral epiphysis. Worsening of scoliosis, even in scoliosis, with the familial consent and the consent of the orthopedic surgeon, I've still gone ahead after a very, very detailed discussion and agreement by the family. So this is a Turner syndrome, but look at those 2 karyotyping. The one below is also a Turner syndrome. You have any number of times to get a report where there is 46XX saying this is a normal karyotype. No, the short arm of chromosome X, the P arm is most important, the X chromosome. When you have iso-Q in karyotyping, you have 46XX and no P arm, that is also a Turner syndrome variant. So I've got quite a few patients with iso-Q. So Turner syndrome, you don't have to have clinical markers. Your karyotyping has to be absolutely specific. So use of growth hormone therapy in Turner syndrome, it is not only for height, it also improves lean body mass. It reduces adiposity. It has an excellent benefit on the lipoprotein profile and reduces the atherogenic index and improves bone mineral density. So this is, I would say, a synonymous situation like an SGA. It's an extreme SGA. So this is one of my children, or two of them actually. Those two are another child, and these two are the same. Russell-Silver syndrome, severe SGA. They confirm their diagnosis by using the Netschin's criteria, or we use another criteria to confirm diagnosis. Genetics is not absolutely imperative. If you have it, well and good, but remember, only 60% will have a genetic mutation which can be picked up well, and methylation defects have to be looked for. But this is a severe situation of an SGA. So they are severely hypotonic. Once you start growth hormone, they start gaining muscle strength and they really become mobile. They're usually more intelligent than their surrounding people. I had to work really hard on him, and ultimately we reached 150 centimeters because they also have a risk for early puberty. So growth hormone, insulin-like growth factor is altered in SGA children. Suboptimal nutrition in the last trimester increases growth hormone, reduces IGF-1, IGF-2, IGF-BP3, reduces insulin and increases IGF-BP1. So you have growth hormone hypersecretion in the later part of, early part of neonatal period, and that is why you're looking at catch-up growth. If you don't have catch-up growth, by 2 years, then you actually qualify for growth hormone therapy. SGA children may also have a partial growth hormone resistance, and that is another reason for a higher dosing. They are small sized at birth. 80% of SGA children achieve normal supine length by 6 months of age, enhanced to 86% by 12 months of age, and catch-up is usually achieved by 2 years of age. 8 to 14% of SGA may have short stature, and when you define short stature by length, it's much more important than when you define it by weight. But to get a length is very difficult in our scenario because not all centers measure length at birth. Growth hormone therapy in SGA, the pubertal onset is usually normal in boys. They have an early puberty in girls. When you have early puberty, you start early, you finish early, the number of years you have left for growth is compromised again. So puberty will also interfere with the ultimate growth potential you could get. So growth hormone treatment in SGA with persisting short stature improves adult height. The earlier you start and the shorter and lighter at start, the better the long-term responses. So this is webbing of the neck. You have a similar picture like a Turner syndrome. Karyotyping is normal. This is Noonan's. Because there's an autosomal dominant, that is the mother and the brother. And look at their hands and the type of digital abnormalities they have. This is a family of Noonan syndrome. This is Prader-Willi syndrome, a typical hypotonia, severe hypotonia at birth, has feeding difficulties, starts gaining weight by 2 to 3 years of age, has acromicria, almond-shaped eyes, and huge morbid obesity with severe hypothalamic appetite. So growth hormone therapy in Prader-Willi syndrome, you don't have to have a growth hormone stimulation test. If you want, yes, for certain situations, you do it. Lot of studies talk about growth hormone deficiency in about 40 to 100%. SGA versus AGA, the difficulties in growth hormone testing, the bone age is variable because of obesity, which will interfere with IGF-1. So it has huge amounts of beneficial effects on body composition. It reduces your fat mass and increases your muscle mass, improves cognition, it reduces your physical characteristics, it increases motor strength and mental speed. Remember, you have to look at obstructive sleep apnea, and if they have obstructive sleep apnea, you have to take remedial measures and put them on BiPAP before you start growth hormone because there is always a risk of sudden death. These are some of our other patients for whom we have used growth hormone. This is orofaciodigital syndrome type 6 Varadi, and that's his ultimate height after being treated with growth hormone for several years. Luckily, he went into spontaneous puberty. This is some of our other patients for whom we've tried. For this child, this was very sick. We couldn't do anything much. So this is severe hypotonia with persistent fetal pads. That eye is remarkably similar for or helpful in the diagnosis. That is Kabuki syndrome, which is equivalent to the Kabuki makeup of the Japanese drama. So where else do we use growth hormone? Adult growth hormone deficiency, precocious puberty on its own is a huge lecture, familial short stature, prematurity, they will still grow but later, so you will have to think doubly or triply several times before you think of using growth hormone in prematurity when they are AGA. Skeletal dysplasia, it's a questionable use. Hypophosphatemic rickets, yes and no on certain situations. In 18q minus, I found it beneficial, but again, it's a very dicey situation, previous malignancies, Verheidt syndrome, I did not find it useful, and several other situations, you can put them all under idiopathic short stature. Thank you so much, and that's messy. You went through growth hormone therapy.